Question 1. A 45-year-old male presents with complaints of chronic fatigue, weight loss, and increased thirst. His blood pressure is found to be elevated at 106 to 95 mmHg. By examination, he has a slight hyperpigmentation of his skin, especially in sun-exposed areas. Laboratory results show elevated serum ACT and low cortisol levels. Based on this clinical presentation, which of the following is the most? Diagnosis: A. Primary hyperaldosteronism. B. Addison's disease. C. Cushing's disease. D. Hypopituitarism. Answer: B. Addison's disease. Explanation: this patient is presenting with symptoms consistent with Addison's disease, which is primary adrenal insufficiency. Addison's disease is characterized by progressive fatigue, weight loss, hyperpigmentation, and hypotension. The increased ACT level is the compensatory response due to a lack of cortisol production. Hyperpigmentation occurs because ACT also stimulates melanocytes, leading to increased melanin production. The low cortisol levels confirm adrenal insufficiency. In contrast, Cushing's disease, option C, would present with elevated cortisol levels. 2. A pituitary tumor and hyperaldosteronism, option A, is characterized by hypertension and hypokalemia, not hyperpigmentation. Hypopituitarism, option D, may result in multiple hormonal deficiencies but would not specifically cause these symptoms. Question 2. Mr. Collins is a 68-year-old male with a long history of smoking. He is currently presenting with progressive shortness of breath, chronic cough, and sputum production. Chest X-ray shows hyperinflated lungs with flattened diaphragms. Pulmonary function tests reveal a decreased FeFC ratio. What is the most likely diagnosis for Mr. Collins' condition? A. Asthma. B. Chronic obstructive pulmonary disease, COP. C. Pneumonia. D. Pulmonary fibrosis. Answer: B. Chronic obstructive pulmonary disease, COPT. Explanation: Mr. Collins' clinical symptoms and history of smoking point towards chronic obstructive pulmonary disease, COPT. Group of diseases including chronic bronchitis and emphysema characterized by progressive airflow limitation. The hyperinflated lungs on X-ray and flattened diaphragms are indicative of emphysema. The decreased FeFC ratio on pulmonary function tests is obstructive lung diseases, particularly COPT. In contrast, asthma, option A, typically presents with variable airflow obstruction and may not have significant smoking history. Pneumonia, option C, would present with fever, productive cough, and consolidation on chest X-ray. Pulmonary fibrosis, option D, would cause restrictive lung disease and would typically present with reduced lung volumes rather than hyperinflation. Question 3, scenario-based. Dr. Patel is seeing a 32-year-old pregnant woman, Mrs. Thompson, who is in her second trimester. Mrs. Thompson reports that she has been feeling increasingly fatigued, has noticed slight swelling in her legs, and is having difficulty catching her breath when walking up the stairs. On examination, her blood pressure is elevated at 149 mmHg and she has mild peripheral edema. Urinalysis reveals 1 proteinuria. What should Dr. Patel be most concerned about in this case? A. Preeclampsia. B. Gestational diabetes. C. Deep vein thrombosis. D. Normal pregnancy changes. Answer A. Preeclampsia. Explanation: Mrs. Thompson's clinical presentation is concerning for preeclampsia, hypertensive disorder of pregnancy that typically occurs after the 20th week of gestation. The key features in this case are elevated blood pressure greater than 149 mmHg, peripheral edema, and proteinuria. These signs suggest that the patient may be eclampsia and organ damage if left untreated. The condition, characterized by new onset hypertension and proteinuria after 20 weeks of gestation. Gestational diabetes, option B, typically presents with elevated blood sugar levels, but does not typically cause hypertension or proteinuria. Deep vein thrombosis, option C, may present with lake swelling, but is less likely to be associated with hypertension and proteinuria. Normal pregnancy changes, option D, can include mild edema and fatigue, but these should not cause significant hypertension or proteinuria. Therefore, the most likely concern in this case is preeclampsia, which requires close monitoring and management to prevent further complications. Question 4. A 55-year-old male with a history of hypertension presents with sudden onset chest pain radiating to his left arm, shortness of breath, and diaphoresis. His vital signs show a blood pressure of 179 mmHg, a heart rate of 110 beats per minute, and a respiratory rate of 22 breaths per minute. His electrocardiogram X shows some segment elevation in a Roman tomb and depth. On the clinical findings, which of the following is the most likely diagnosis? A. Acute pericarditis. B. Acute myocardial infarction, MI. C. Pulmonary embolism. D. Aortic dissection. Answer B. Acute myocardial infarction. My explanation. This patient presents with classic signs of acute myocardial infarction, including chest pain radiating to the left arm, shortness of breath, diaphoresis, and an elevated heart rate. The IC findings shown since segment elevation aromatumna are indicative of inferior wall STEMI elevation myocardial infarction, which is a form of MI caused by obstruct a coronary artery. Acute pericarditis option A typically causes sharp pleuritic chest pain that worsens with deep breaths or lying down, and it usually does not cause since segment elevation in specific leads as seen in MI. Pulmonary embolism option C may cause sudden chest pain and shortness of breath, but typically presents with a clear history of risk factors, e.g. deep vein thrombosis, recent surgery, and would show change in the and often a positive D-dimer aortic dissection option D presents with sudden severe chest pain that is often described as tearing or ripping in nature, and it typically involves aortic rupture or compromise, which is not consistent with the patient's current presentation. Thus, this patient's presentation is most consistent with acute myocardial infarction and requires immediate intervention, e.g. antiplatelet therapy, thrombolytics, or angioplasty. Question 5. A 35-year-old female presents with a 3-day history of right-sided abdominal pain, nausea, and vomiting. She is febrile with a temperature of 101.5 deg, 38.6 deg, and has tenderness in the right lower quadrant on examination. On laboratory workup, her white blood cell count is elevated. Ultrasound shows thickened distended appendix. What is the most likely diagnosis? A. Acute appendicitis. B. Ovarian torsion. C. Ectopic pregnancy. D. Cholecystitis. Answer A. Acute appendicitis. Explanation. This patient presents with typical symptoms of acute appendicitis, including right lower quadrant abdominal pain, fever, nausea, vomiting, and leukocytosis. The ultrasound finding of a thickened and distended appendix confirms the diagnosis. Acute appendicitis is a common surgical emergency caused by obstruction of the appendix leading to inflammation and infection. Ovarian torsion option B. Present with similar abdominal pain and vomiting, but it is more commonly associated with a history of ovarian cysts or other gynecological issues, and the ultrasound would typically show an enlarged ovary with a twisted pedicle. Ectopic pregnancy option C should always be considered in women of reproductive age with abdominal pain, but it is more commonly associated with positive pregnancy tests and may show an adnexal mass or free flu on ultrasound. Cholecystitis option D causes right upper quadrant pain, not lower quadrant pain, and is typically associated with a history of gallstones or risk factors for biliary disease. Ultrasound findings would reveal gallstones or a thickened gallbladder wall, which is not the case here. The most likely diagnosis is acute appendicitis, which often requires surgical intervention, appendectomy. Question 6, scenario-based. Mr. Harris, a 72-year-old male, presents to the emergency department with a history of confusion, lethargy, and recent weight loss. He was diagnosed with prostate cancer 2 years ago and has been undergoing hormonal therapy. On examination, he is disoriented, has generalized weakness, and has diminished deep tendon reflexes. Laboratory results show elevated calcium levels, and a chest X-ray reveals a lytic lesion in the spine. What is the most likely cause of Mr. Harris's symptoms? A. Hypocalcemia of malignancy. B. Hypothyroidism. C. Severe vitamin D deficiency. D. Chronic kidney disease. Answer A. Hypocalcemia of malignancy. Explanation. Mr. Harris's presentation is highly suggestive of hypocalcemia of malignancy, which is commonly seen in patients with cancer, especially those with metastatic bone disease. His prostate cancer diagnosis, the lytic lesion on the chest X-ray, and the elevated calcium levels strongly point to this condition. Hypocalcemia of malignancy occurs when cancer spreads to the bone, as seen here in the spinal lesion, causing the release of calcium into the bloodstream. It is often seen in prostate cancer and can present with confusion, lethargy, weakness, and hyperreflexia, similar to Mr. Harris's symptoms. Hypothyroidism option B may present with symptoms such as fatigue, weight gain, and depression, but it is not typically associated with elevated calcium levels or lytic bone lesions. Severe vitamin D deficiency option C can cause weakness, own pain, but it is unlikely to lead to hypocalcemia or the specific findings of metastatic cancer. Chronic kidney disease option D can cause confusion and electrolyte disturbances, but it is typically associated with hyperkalemia, acidosis, and other kidney-related findings, rather than elevated calcium and lytic bone lesions. In this case, hypercalcemia of malignancy is the most likely cause of his symptoms, and prompt treatment, e.g. bisphosphonates, hydration, is required to manage the hypercalcemia and address the underlying malignancy. Question 7. A 28-year-old male presents with fever, sore throat, and a characteristic rash of red macules that progress to vesicles, followed by crusting. The rash first appeared on his face and spread to his trunk and extremities. He reports a recent exposure to a person diagnosed with varicella zoster vice (VV). Which of the following is the most appropriate management for this patient? A. Intravenous antibiotics. B. Oral acyclovir. C. Oral prednisone. D. Topical antifungal cream. Answer: B. Oral acyclovir. Explanation: this patient is presenting with varicella chickenpox, characterized by the appearance of a red maculopapular rash that progresses to vesicles, followed by crusting. The recent exposure to a person diagnosed with varicella raises the suspicion for active infection, which is best managed with oral acyclovir. Option B, an antiviral medication that reduces the duration and severity of the illness. Intravenous antibiotics, option A, are not indicated unless there is a secondary bacterial infection. Or prednisone, option C, is contraindicated during a viral infection like varicella, as steroids can predispose to severe complications. Topical antifungal cream, option D, is inappropriate as the rash is viral, not fungal. Thus, antiviral therapy with acyclovir is appropriate in managing varicella. Question 8. A 45-year-old female with a history of type 2 diabetes presents with new-onset visual changes, difficulty reading, and mild pain in her right eye. Upon examination, the right eye shows a relative afferent pupillary defect, and fundoscopy reveals cotton wool spots and microaneurysms. What is the most likely diagnosis? A. Diabetic retinopathy. B. Macular degeneration. C. Retinal detachment. D. Optic neuritis. Answer: A. Diabetic retinopathy. Explanation: the patient's history of type 2 diabetes and the findings on fundoscopy, such as cotton, wool spots, and microaneurysms, are classic signs of diabetic retinopathy. This condition is a common complication of long-standing diabetes, resulting from damage to the small blood vessels in the retina. Macular degeneration, option B, typically causes gradual central vision loss, not the described find in this case, and is unrelated to diabetes. Retinal detachment, option C, would cause sudden painless vision loss and possibly flashes of light or floaters, but it would not show cotton wool spots or microaneurysms. Optic neuritis, option D, involves inflammation of the optic nerve and presence with pain with eye movement and vision loss, but it does not cause the retinal findings seen in this patient. Thus, the most likely diagnosis is diabetic retinopathy. Question 9, scenario-based. A 60-year-old male with a history of hypertension and chronic smoking presents with sudden onset shortness of breath, pleuritic chest pain, and tachypnea. His oxygen saturation is 88% and his heart rate is 110 beats per minute. On examination, his right leg shows swelling and redness. The D-dimer test is elevated and a pulmonary angiogram reveals a large pulmonary embolism. What is the next step in management? A. Initiate anticoagulation therapy. B. Perform thrombolysis. C. Administer a beta blocker. D. Start a statin. Answer: A. Initiate anticoagulation therapy. Explanation: this patient presents with classic symptoms of pulmonary embolism, P, including sudden onset shortness of breath, pleuritic chest pain, tachypnea, and signs of deep vein thrombus in the leg. The elevated D-dimer and CT pulmonary angiogram confirming a large P indicate the need for immediate anticoagulation therapy, option A, to prevent further clot formation. Facilitate resolution of the embolism. Thrombolysis, option B, is indicated in patients with massive or life-threatening P, particularly those with hemodynamic instability, but this patient's presentation does not suggest such severe compromise. Beta blockers, option C, are contraindicated in patients with P, especially if they are hemodynamically unstable, as they can exacerbate the condition. Statins, option D, are used for cholesterol management but are not appropriate for the acute treatment of P. Thus, the immediate next step is to initiate anticoagulation therapy. Question 10. A 55-year-old male with a history of chronic alcohol use presents with confusion, ataxia, and nystagmus. He reports poor nutrition and a lack of vitamin supplementation for several months. On examination, he has an unsteady gait, bilateral horizontal nystagmus, and ophthalmoplegia. What is the most likely diagnosis? A. Wernicke encephalopathy. B. Multiple sclerosis. C. Alcoholic liver disease. D. Parkinson's disease. Answer A. Wernicke encephalopathy. Explanation: this patient presents with classic signs of Wernicke encephalopathy, including confusion, ataxia, nystagmus, and ophthalmoplegia, which are due to thiamine, vitamin B deficiency. The patient's chronic alcohol use and poor nutritional intake are key risk factors for this condition, which is medical emergency requiring immediate thiamine supplementation. Multiple sclerosis option B, typically with episodes of neurological deficits such as weakness or sensory disturbances, but it is not associated with the acute confusion and ataxia seen here. Alcoholic liver disease option C may cause confusion and other neurological symptoms, but it would not explain the specific findings of nystagmus and ophthalmoplegia. Parkinson's disease option D is neurodegenerative disorder characterized by bradykinesia, rigidity, and tremor, but it does not present with the acute symptoms seen in this patient. Thus, the most likely diagnosis is Wernicke encephalopathy, which requires urgent thiamine replacement. Question 11. A 72-year-old female presents with a 3-month history of increasing difficulty swallowing, unintentional weight loss, and a hoarse voice. On examination, she has a palpable mass in her neck, and her thyroid is slightly enlarged. A fine needle aspiration biopsy of the nodule reveals follicular cells with nuclear features suggestive of malignancy. Which of the following is the most likely diagnosis? A. Medullary thyroid carcinoma. B. Anaplastic thyroid carcinoma. C. Papillary thyroid carcinoma. D. Follicular thyroid carcinoma. Answer D. Follicular thyroid carcinoma. Explanation: this patient's symptoms and biopsy findings are most suggestive of follicular thyroid carcinoma, FTC, which is a differentiated thyroid cancer. FTC is characterized by the presence of follicular cells with nuclear atypia, but is typically more aggressive than papillary thyroid carcinoma, option C, which is the most common thyroid cancer. FTC is distinct from medullary thyroid carcinoma, option A, which arises from parafollicular C cells and is associated with elevated calcitonin levels. Anaplastic thyroid carcinoma, option B, is a very aggressive and rare cancer with a poor prognosis, but it does not typically present with the same nuclear features found in follicular carcinoma. Thus, the most likely diagnosis is follicular thyroid carcinoma. Question 12. A 38-year-old male with a history of asthma presents with a 2-day history of fever, chills, cough, and difficulty breathing. He has a productive cough with green sputum. On physical exam, his temperature is 102 deg, 38.9 deg, heart rate 110 bpm, and respiratory rate 22 min. Lung auscultation reveals dullness to percussion and decreased breath sounds in the right lower lobe. Chest X-ray shows consolidation in the right lower lobe. Which of the following is the most appropriate treatment? A. Oral antibiotics targeting Streptococcus pneumoniae. B. Intravenous antibiotics and drainage of the pleural effusion. C. Inhaled corticosteroids. D. Intravenous immunoglobulin therapy. Answer B. Intravenous antibiotics and drainage of the pleural effusion. Explanation: this patient presents with signs of community-acquired pneumonia CAP complicated by apparent pneumonic effusion or empyema, as indicated by the consolidation on chest X-ray and the physical exam findings e.g. dullness to percussion. Empiric treatment for CAP often includes intravenous antibiotics that target common pathogens such as Streptococcus pneumoniae, but in the setting of a pleural effusion, drainage is also necessary to prevent complications like abscess formation. Oral antibiotics, option A, are appropriate for uncomplicated CAP but not for cases complicated by effusion or empyema. Inhaled corticosteroids, option C, are used for asthma management but not for acute pneumonia. Intravenous immunoglobulin therapy, option D, is not indicated for CAP or pleural effusion. Thus, the most appropriate treatment is intravenous antibiotics and drainage. Question 13, scenario-based. A 45-year-old male with a history of chronic hepatitis C presents with new-onset jaundice, dark urine, and fatigue. His liver function tests show an elevated total bilirubin of 6.5 mg/dl, alanine aminotransferase ALT of 180 ul, and aspartate aminotransferase AST of 220 ul. His hepatitis or NE are positive, and he has genotype 1 infection. Which of the following is the most appropriate management strategy? A. Immediate liver transplant. B. Antiviral therapy with direct-acting antivirals. Does. C. Interferon-based therapy. D. Supportive care and observation. Answer: B. Antiviral therapy with direct-acting antivirals. Does. Explanation: this patient presents with acute exacerbation of chronic hepatitis C characterized by elevated liver enzymes and jaundice. The most appropriate treatment is antiviral therapy with direct-acting antivirals (DOS), which are highly effective in eradicating the hepatitis C virus (HCV) and reducing the risk of liver failure and cirrhosis. Liver transplant. Option A is only necessary for patients with end-stage liver disease or hepatic failure, not for all cases of hepatitis C. Interferon-based therapy, option C, is no longer the first-line treatment due to its significant side effects and lower efficacy compared to DOS. Supportive care, option D, alone is insufficient in managing hepatitis C, especially when antiviral therapy is available. Thus, the most appropriate treatment is direct-acting antiviral therapy. Question 14. A 60-year-old male with a history of chronic obstructive pulmonary disease, COPD, presents with worsening shortness of breath, increased sputum production, and a low-grade fever for the past 2 days. On examination, his oxygen saturation is 88% on room air. Chest X-ray reveals increased lung markings, but no consolidation or pleural effusion. What is the most appropriate next step in management? A. Administer oral corticosteroids and antibiotics. B. Perform a bronchoscopy. C. Start intravenous fluids and intensive care unit IQ monitoring. D. Initiate non-invasive positive pressure ventilation NIV. Answer A. Administer oral corticosteroids and antibiotics. Explanation: this patient is presenting with an acute exacerbation of COPD, likely triggered by a respiratory infection. The initial management includes oral corticosteroids to reduce inflammation and antibiotics if the bacterial infection is suspected, e.g. Haemophilus influenzae or Streptococcus pneumoniae. The chest X-ray does not show evidence of a severe infection, but low oxygen saturation and symptoms suggest that appropriate medical therapy is necessary. Bronchoscopy, option B, is not indicated unless there is suspicion of a foreign body or other obstruction, which is not suggested here. Intravenous fluids and IQ monitoring, option C, are not required for mild exacerbations, and the patient can be managed on an outpatient basis. Non-invasive positive pressure ventilation (NIV), option D, may be necessary for more severe cases of COPD exacerbation with respiratory acidosis or severe hypoxemia, but is not the first-line treatment for this patient. Thus, the most appropriate next step is to administer corticosteroids and antibiotics. Question 15. A 23-year-old female presents with a 3-day history of fever, sore throat, and a characteristic sandpaper-like rash on her neck and upper chest. She also has a red tongue with a strawberry appearance. The rapid strep test is positive. What is the most likely diagnosis? A. Scarlet fever. B. Infectious mononucleosis. C. Measles. D. Rubella. Answer A. Scarlet fever. Explanation: this patient's presentation of fever, sore throat, a sandpaper-like rash, and a strawberry tongue is classic for scarlet fever, which is caused by group a Streptococcus gas. Scarlet fever is a complication of streptococcal pharyngitis and is characterized by the rash that starts on the neck and chest and spreads to other parts of the body. Infectious mononucleosis, option B, caused by Epstein-Barr, would present with a sore throat, fever, and enlarged lymph nodes, but lacks the characteristic rash and strawberry tongue. A measles, option C, presents with a morbilliform rash that begins at the hairline and spreads downward, along with Koplik spots in the mouth, neither of which are seen here. Rubella, option D, presents with a maculopapular rash, not the sandpaper-like texture of the rash seen in scarlet fever. Thus, the most likely diagnosis is fever. Question 16. A 55-year-old female with a history of hypertension and diabetes presents with sudden onset chest pain, shortness of breath, and diaphoresis. She appears anxious and restless. Her blood pressure is 106 to 90 mm Hg, heart rate 110 bpm, and respiratory rate 20 min. An electrocardiogram X shows segment elevation in a Roman nerve. Which of the following is the most likely diagnosis? A. Unstable angina. B. Acute pericarditis. C. Acute myocardial infarction STEMI. D. Pulmonary embolism. Answer C. Acute myocardial infarction STEMI. Explanation: Is patient presents with classic symptoms of an acute myocardial infarction STEMI characterized by sudden onset chest pain, shortness of breath, diaphoresis, and sense segment elevation in the inferior omentum nerve. The most likely diagnosis is sense segment elevation myocardial infarction STEMI. Unstable angina, option A, can present with chest pain but does not cause sense segment elevation. Acute pericarditis, option B, may present with chest pain and a pericardial rub but typically does not cause sense segment elevation in the inferior leads. Pulmonary embolism, option D, may present with chest pain and shortness of breath, but it usually causes right heart strain and does not lead to sense segment elevation. Thus, the most likely diagnosis is STEMI. Question 17. A 72-year-old male presents with a 6-month history of progressive weakness, fatigue, and weight loss. He also reports night sweats and a persistent dry cough. Physical examination reveals lymphadenopathy and hepatosplenomegaly. A bone marrow biopsy reveals the presence of malignant lymphocytes. Where's the most likely diagnosis? A. Chronic lymphocytic leukemia CLL. B. Non-Hodgkin lymphoma. C. Hodgkin lymphoma. D. Acute myeloid leukemia. Answer A. Chronic lymphocytic leukemia CLL. Explanation: this patient has symptoms and findings consistent with chronic lymphocytic leukemia CLL, which commonly presents with progressive weakness, fatigue, weight loss, night sweats, and lymphadenopathy in older adults. The bone marrow biopsy revealing malignant lymphocytes further supports this diagnosis. Non-Hodgkin lymphoma, option B, is a possibility but typically presents with localized lymphadenopathy and may have more rapid progression. Hodgkin lymphoma, option C, typically presents with bimodal age distribution. Young adults and older adults, and the presence of Reed-Sternberg cells on biopsy would be more suggestive. Acute myeloid leukemia, option D, presents more acutely with symptoms of bone marrow failure, including anemia, bleeding, and infections, not with chronic symptoms of malignant lymphocytes. Thus, the most likely diagnosis is CL. Question 18, scenario-based. A 40-year-old woman with a history of obesity and hypertension presents with a 2-week history of a productive cough, pleuritic chest pain, and fever. She denies recent travel or sick contacts. On examination, her temperature is 101 Deg, 38.3 Deg, and her oxygen saturation is 92% on room air. Chest X-ray shows consolidation in the right lower lobe. Sputum culture grows Streptococcus pneumoniae. Which of the following is the most appropriate treatment? A. Oral azithromycin. B. Intravenous ceftriaxone and azithromycin. C. Oral amoxicillin. D. Oral levofloxacin. Answer: B. Intravenous ceftriaxone and azithromycin. Explanation: this patient has community-acquired pneumonia CAP with consolidation on chest X-ray and a positive sputum culture for Streptococcus pneumoniae. The treatment of choice for moderate to severe CAP in patients with comorbidities like obesity and hypertension includes intravenous ceftriaxone, a broad-spectrum antibiotic, plus azithromycin to cover atypical pathogens such as Mycoplasma pneumoniae. Oral azithromycin, option A, is typically used for outpatient treatment of CAP, but this patient's symptoms and chest X-ray findings suggest need for intravenous antibiotics. Oral amoxicillin, option C, is typically used for less severe cases of CAP without comorbidities. Oral levofloxacin, option D, could be considered but is usually reserved for patients who are either allergic to first-line treatments or have resistant organisms. Thus, the most appropriate treatment is intravenous ceftriaxone and azithromycin. Question 19. A 26-year-old female presents with complaints of dysuria, urinary frequency, and urgency. She also notes low abdominal discomfort. Urinalysis reveals positive leukocytesterase and nitrites, along with white blood cells. Which of the following is the most likely diagnosis? A. Acute cystitis. B. Pyelonephritis. C. Interstitial cystitis. D. Urinary tract stones. Answer A. Acute cystitis. Explanation: this patient has acute cystitis, which is characterized by dysuria, frequency, urgency, and lower abdominal discomfort. The presence of positive leukocytesterase, nitrites, and white blood cells on urinalysis confirms a bacterial infection of the lower urinary tract. Pyelonephritis, option B, is a more severe infection that involves the kidneys and often presents with fever, flank pain, and symptoms, which this patient does not have. Interstitial cystitis, option C, is a chronic condition characterized by pelvic pain and urinary urgency but does not show the typical signs of infection on urinalysis. Urinary tract stones, option D, may cause abdominal discomfort and urinary symptoms but are usually associated with hematuria rather than the infection findings on urinalysis. Thus, the most likely diagnosis is acute cystitis. Question 20. A 50-year-old male presents with gradual onset of muscle weakness and fatigue over the past 6 months. He also notes difficulty climbing stairs and getting up from a seated position. Physical exam reveals proximal muscle weakness but no sensory deficits or reflex changes. The serum creatine kinase level is significantly elevated. Which of the following is the most likely diagnosis? A. Duchenne muscular dystrophy. B. Myasthenia gravis. C. Polymyositis. D. Guillain-Barré syndrome. Answer: C. Polymyositis. Explanation: this patient's symptoms of proximal muscle weakness and elevated creatine kinase are most suggestive of polymyositis and inflammatory myopathy. It typically affects the proximal muscles, e.g. shoulders, hips, and is associated with elevated creatine kinase. Duchenne muscular dystrophy, option A, is a genetic disorder that presents earlier in life, typically in childhood, and affects both proximal distal muscles, but it is not typically associated with elevated creatine kinase in adults. Myasthenia gravis, option B, presents with fatigue and muscle weakness, but it is characterized by ptosis and diplopia and is not associated with elevated creatine kinase. Guillain-Barré syndrome, option D, is an acute condition that often presents with ascending paralysis, sensory deficits, and areflexia, which this patient does not have. Thus, the likely diagnosis is polymyositis. Question 21. A 55-year-old male with a history of smoking and alcohol use presents with a 2-month history of progressive cough, hemoptysis, and weight loss. A chest X-ray reveals a mass in the upper lobe of the right lung. A biopsy confirms the presence of small cell lung cancer. Which of the following is the most appropriate next step in management? A. Chemotherapy and radiation therapy. B. Surgical resection. C. Immunotherapy. D. Palliative care. Answer: A. Chemotherapy and radiation therapy. Explanation: this patient has small cell lung cancer (SLE), a highly aggressive form of lung cancer that typically presents with symptoms such as progressive cough, hemoptysis, and weight loss. Small cell lung cancer is not amenable to surgical resection due to its tendency to metastasize early, and it is typically treated with chemotherapy and radiation. Surgical resection, option B, is not appropriate. Small cell lung cancer due to its advanced stage at diagnosis. Immunotherapy, option C, is a promising treatment for certain cancers but is not the first-line treatment for small cell lung cancer, which typically responds better to chemotherapy. Palliative care, option D, is appropriate for patients with advanced incurable cancer, but the patient in this scenario still requires aggressive treatment. Thus, the most appropriate next step is chemotherapy and radiation therapy. Question 22. A 60-year-old male presents with a history of chronic lower back pain and numbness in his legs that has progressively worsened over the past year. He also has difficulty with urination and reports some bowel incontinence. On examination, he has muscle weakness, decreased reflexes in his lower extremities, and sensory loss in the saddle distribution. What is the most likely diagnosis? A. Cauda equina syndrome. B. Spinal cord compression. C. Multiple sclerosis. D. Parkinson's disease. Answer: A. Cauda equina syndrome. Explanation: this patient has symptoms that are highly suggestive of cauda equina syndrome, which is characterized by lower back pain, saddle anesthesia, motor weakness, reflex changes, and bladder bowel dysfunction, e.g. urinary retention or incontinence. Cauda equina syndrome occurs due to compression of the cauda equina nerves at the lumbar level and is a medical emergency. Spinal cord compression, option B, cause similar symptoms, but it typically presents with upper motor neuron signs, e.g. hyperreflexia, spasticity, which this patient does not have. Multiple sclerosis, option C, is a demyelinating disorder that can present with neurologic deficits, but it typically causes episodes of neurologic impairment rather than the progressive weakness and incontinence seen in this patient. Parkinson's disease, option D, affects movement and does not cause saddle anesthesia or bladder and bowel incontinence. Thus, the most likely diagnosis is cauda equina syndrome. Question 23, scenario-based. A 45-year-old woman presents with abdominal pain and jaundice. She has a history of hepatitis C and alcohol use. A liver ultrasound shows splenomegaly and ascites. Laboratory tests reveal low albumin and elevated bilirubin. What is the most likely diagnosis? A. Hepatocellular carcinoma. B. Cirrhosis. C. Acute hepatitis. D. Gallstones. Answer: B. Cirrhosis. Explanation: This patient's symptoms of abdominal pain, jaundice, splenomegaly, and ascites, combined with history of hepatitis C and alcohol use, are highly suggestive of cirrhosis. Cirrhosis is a late stage of chronic liver disease that results in fibrosis, portal hypertension, and complications like ascites and splenomegaly. Hepatocellular carcinoma, option A, is possible complication of cirrhosis, but its presence with unexplained weight loss, liver mass, and elevated alpha-fetoprotein, which are not mentioned in this case. Acute hepatitis, option C, is characterized by elevated liver enzymes and viral markers, e.g. hepatitis C serology, but does not typically cause splenomegaly or ascites unless there is significant liver damage leading to cirrhosis. Gallstones, option D, can cause jaundice but usually result in biliary colic, cholecystitis, not splenomegaly and ascites. Thus, the most likely diagnosis is cirrhosis. Question 24. A 30-year-old male presents with severe headache, nausea, and photophobia. On physical exam, he has a positive Brzezinski sign and Koenig sign. A lumbar puncture reveals increased opening pressure, low glucose, high protein, and elevated white blood cells with a predominance of neutrophils. What is the most likely diagnosis? A. Viral meningitis. B. Bacterial meningitis. C. Fungal meningitis. D. Subarachnoid hemorrhage. Answer: B. Bacterial meningitis. Explanation: this patient has classic signs of bacterial meningitis, which typically presents with severe headache, nausea, photophobia, and positive signs of meningeal irritation, e.g. Brzezinski sign and Koenig sign. The lumbar puncture findings of low glucose, high protein, and elevated white blood cells, predominantly neutrophils, are characteristic of bacterial meningitis. Viral meningitis, option A, typically presents with a normal glucose level, moderate increase in white blood cells, and lymphocytic predominance on lumbar puncture. Fungal meningitis, option C, is usually seen in immunocompromised patients and has a more insidious onset with elevated opening pressure, low glucose, and lymphocytic predominance. Subarachnoid hemorrhage, option D, can present with a severe headache, but the lumbar puncture findings would show fluid and xanthochromia, not the findings seen here. Thus, the most likely diagnosis is bacterial meningitis. Question 25. A 70-year-old woman with a history of hypertension and diabetes presents with acute onset of left-sided weakness and difficulty speaking. Her blood pressure is 108 to 110 mm Hg and her heart rate is 85 bpm. Aiken reveals a right-sided ischemic stroke. What is the most appropriate initial treatment? A. Intravenous tissue plasminogen activator, TPA. B. Antiplatelet therapy. C. Blood pressure lowering medications. D. Anticoagulation therapy. Answer A. Intravenous tissue plasminogen activator, EPA. Explanation: this patient is presenting with signs of an acute ischemic stroke, including left-sided weakness and difficulty speaking. The most appropriate initial treatment for an acute ischemic stroke is intravenous tissue plasminogen activator, TPA, which can be administered within 3 to 4.5 hours of symptom onset to break down the clot and restore blood flow. Antiplatelet therapy, option B, is appropriate for secondary prevention of stroke but is not used in the acute phase of ischemic stroke. Blood pressure lowering medications, option C, should be considered in the long-term management of stroke patients but are not typically used in the acute phase unless the blood pressure is extremely high and there are signs of hypertensive encephalopathy. Anticoagulation therapy, option D, is not indicated for an ischemic stroke unless the patient has atrial fibrillation or another condition that warrants anticoagulation. Thus, the most appropriate initial treatment is intravenous tissue plasminogen activator, TPA. Question 26. A 24-year-old woman presents with fatigue, weight loss, polyuria, and polydipsia. Laboratory results reveal a random blood glucose of 208 mgl, elevated HbAC, and positive urine ketones. The patient is diagnosed with type 1 diabetes mellitus. Which of the following is the most important step in her initial management? A. Start insulin therapy. B. Start metformin therapy. C. Initiate a low-carbohydrate diet. D. Prescribe oral sulfonylureas. Answer A. Start insulin therapy. Explanation: this patient's presentation with polyuria, polydipsia, weight loss, and elevated blood glucose is consistent with type 1 diabetes mellitus, TDM. The initial treatment for type 1 diabetes involves insulin therapy since the pancreas produces little or no insulin in this condition. Metformin therapy, option B, is used in type 2 diabetes to improve insulin sensitivity. Type 1 diabetes, low carbohydrate diet, option C, can be beneficial in managing diabetes but is not the first line treatment for type 1 diabetes. Oral sulfonylureas, option D, stimulate insulin secretion from the pancreas and are used in type 2 diabetes, not type 1 diabetes where insulin therapy is required. Thus, the most important step is to start insulin therapy. Question 27. A 68-year-old man with a history of hypertension, hyperlipidemia, and smoking presents with sudden onset chest pain and shortness of breath. His ictus segment elevation in leads VVV and cardiac biomarkers are elevated. What is the most likely diagnosis? A. Unstable angina. B. Acute myocardial infarction. C. Pulmonary embolism. D. Aortic dissection. Answer: B. Acute myocardial infarction. My explanation: this patient with chest pain, shortness of breath, some segment elevation in the anterior lead, VV, and elevated cardiac biomarkers is most likely experiencing an acute myocardial infarction. Some segment elevation is indicative of a STEMI which results from complete occlusion of a coronary artery. Unstable angina, option A, can present with chest pain and elevate cardiac biomarkers but does not cause some segment elevation on the ECG. Pulmonary embolism, option C, can present with chest pain and shortness of breath, but typically shows ECG changes such as SET pattern and right heart strain, not segment elevation. Aortic dissection, option D, presents with severe chest pain that may radiate to the back, but the ECG typically does not show segment elevation, and the diagnosis is confirmed. CT angiography. Thus, the most likely diagnosis is an acute myocardial infarction. Question 28, scenario-based. A 45-year-old woman with a history of chronic asthma presents to the emergency department with worsening shortness of breath, wheezing, and chest tightness. She reports using her inhaler more frequently over the past few days but has not experienced relief. On examination, she is tachypneic with decreased breath sounds on auscultation. Which of the following is the most appropriate next step in management? A. Administer intravenous corticosteroids. B. Administer intravenous magnesium sulfate. C. Intubate the patient. D. Increase the dose of her inhaled beta agonist. Answer A. Administer intravenous corticosteroids. Explanation: this patient is presenting with an acute asthma exacerbation. In severe cases where there is worsening shortness of breath, tachypnea, and decreased breath sounds, intravenous corticosteroids are a critical component of therapy to reduce inflammation and improve airway function. Intravenous magnesium sulfate, option B, may be used in severe asthma exacerbations, but steroids should be the first step in managing an exacerbation. Intubation, option C, is reserved for patients with respiratory failure, and this patient has not yet reached that stage. Increasing the dose of inhaled beta agonists, option D, is part of the management but should be combined with systemic corticosteroids in severe cases. Thus, the most appropriate next step is to administer intravenous corticosteroids. Question 29. A 40-year-old man presents with a new rash on his face and joint pain. He has a history of fatigue and photosensitivity. On examination, he has a butterfly-shaped rash across his cheeks and nose. Laboratory tests reveal positive anti-nuclear antibodies on an anti-double-stranded DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Psoriatic arthritis. D. Dermatomyositis. Answer: B. Systemic lupus erythematosus. SLE. Explanation: this patient's presentation with butterfly-shaped rash, fatigue, photosensitivity, and positive on an DNA antibodies is highly suggestive of systemic lupus erythematosus. SLE. The butterfly rash is hallmark feature of SLE, and DNA antibodies are highly specific for this condition. Rheumatoid arthritis, option A, typically causes joint pain and swelling. Is not present with characteristic butterfly rash or photosensitivity. Psoriatic arthritis, option C, is associated with skin changes, e.g. psoriasis, but does not cause butterfly rash or positive DNA antibodies. Dermatomyositis, option D, can cause rash and muscle weakness, but does not typically present with butterfly rash and is not associated with DNA antibodies. Thus, the most likely diagnosis is lupus erythematosus. Question 30. A 72-year-old woman presents with acute onset of confusion, tremor, and rigidity. She has a history of hypertension and diabetes, but no prior history of neurologic disease. Her medications include lisinopril and metformin. On examination, she has resting tremor, bradykinesia, and rigidity. Her gait is shuffling, and she has a masked facies. What is the most likely diagnosis? A. Alzheimer's disease. B. Parkinson's disease. C. Multiple system atrophy. D. Normal pressure hydrocephalus. Answer: B. Parkinson's disease. Explanation: this patient presents with the classic signs of Parkinson's disease, including resting tremor, bradykinesia, rigidity, and a shuffling gait. Masked faces, reduced facial expression is another hallmark sign of Parkinson's disease. Alzheimer's disease, option A, primarily affects memory and cognition, not motor function. Multiple system atrophy, option C, is a rare neurodegenerative disorder that can cause Parkinsonism, but also has other features like autonomic dysfunction, which this patient does not exhibit. Normal pressure hydrocephalus, option D, typically presents with the stridor gait disturbance, cognitive decline, and urinary incontinence, which is not the case. Patient, thus, the most likely diagnosis is Parkinson's disease.